Make a brief announcement. I couldn't find a place in here to put the sign-in sheet, so they're in that table right in front of the auditorium.
I'd like to welcome everybody to Neurology Grand Rounds. We're in a different location than usual, as obviously those who are here have noticed, and I'm sure other people will be filtering in as they figure out that we're not in any of our usual locations. It's our pleasure today to have a guest speaker, and I'm actually not going to introduce him. I'm going to introduce Dr. Surletis, who was instrumental in bringing him here. Our guest speaker is somebody that I've had the pleasure of meeting and interacting with for a number of years now, and I think he's going to have a wonderful talk. I do want to say a little bit about the way that we brought him here. This was brought about by a grant from the CURE Foundation. CURE is Citizens United for Research into Epilepsy, and this was started by some very prominent folks who happen to have a daughter who had epilepsy, and they wanted to do something about that. And CURE is one of the major granting organizations, both for research grants and education grants related to epilepsy. They've been very generous in funding research projects and talks like this to spread the word about modern investigations into epilepsy. And it really is a wonderful way to be able to get everybody up to speed about what's going on in the world of epilepsy these days. So without further ado, I'm going to introduce Dr. Surletis, from one of our newest members of the Department of Neurosurgery. Again, the other brief comment I want to make is that I think this kind of highlights the very close interactions these days that we're having between neurology and neurosurgery, and I think that's an element of great things to come. Dr. Surletis.
Thanks, and thank you everybody for attending this morning, this special grand rounds in particular, to Dr. Greenfield for the introduction, and of course to our guest professor, Dr. Alexopoulos. So I'm going to just read a little bio. I have a more formal bio, and I'll quickly read through it just to introduce him formally. But most of all, I would say that he is a very good mentor and a friend to me in particular. He is in particular a staff epileptologist at the Cleveland Clinic Epilepsy Center, and he's director of the clinical and the research fellowship training programs over there. He has a staff appointment in the Department of Neurosciences at the Lerner Research Institute and directs a neurobehavioral sciences course as well at the Case Western Reserve. So he was born and educated in Greece. I hope you forgive him for that. And he received his medical degree at the University of Athens. He served in the Hellenic Navy before pursuing advanced studies abroad. He completed neurology training at Mount Sinai Hospital, followed by a fellowship in epilepsy, EEG, and clinical neurophysiology in Cleveland Clinic. He obtained a master's degree in public health as well at the Cleveland State University. He joined the faculty of Cleveland Clinic Institute in 2005, and since then he's been a clinical epileptologist there, a neurophysiologist conducting human-related and translational research in epilepsy. So his main interest now is the multimodal integration of imaging and neurophysiology of the epilepsies using innovative approaches, some of which we'll hear about today. These include EEG-fMRI, magnetoencephalography, or MEG, and other techniques like this. His other research interests, of course, include, thankfully, surgical therapy of epilepsies, neurostimulation, and anatomo-electroclinical correlations of seizure manifestations. Most importantly of all, for a Greek to have stayed in Cleveland for at least 14 years tells you about one of two things. Either he's crazy, which I don't think is the case, or, in fact, that he is passionate about epilepsy. And I'm sure you'll appreciate that in his talk today. So, Dr. Alexopoulos, we're very grateful to you for coming. And we look forward to your talk.
Well, thank you for the nice introduction, Dimitri. I am extremely happy, delighted to be here. And indeed, I'm very passionate with epilepsy. I don't think I could be doing anything else in my life, actually. And that is the reason I've been in Cleveland. You know, it's not because the weather is anything to do with our weather in Greece. I wanted to thank you for coming here, and of course I wanted to thank Cure for giving us this opportunity to interact today, and in fact congratulate Cure for doing so in terms of exchanging knowledge, allowing for exchanging knowledge and for interactions in the scientific community. So the topic today is advancing non-invasive localization in epilepsy, and doing so during interictal recordings, because you know that we rely on ictal recordings to make determinations. So we have to bring these patients into the monitoring unit, and we have to take them off medications and keep them there for a while and have them have seizures and so on. And so therefore there is a technique which is not very widespread but has been approved by the FDA and is being used in the United States, which is clinical magnetoencephalography. And then there is a EEG-fMRI also that is being investigated. The truth is that there are centers outside the US that are using it on a regular basis. I wanted to talk to you about both in the evaluation of intractable epilepsies. Here are my disclosures, and I have received funding from these agencies, and I serve in a few committees related to epilepsy. So the plan here is we're going to go through history and conceptual concepts introduction, and then I would like to talk to you about the problem. I would like to talk to you as to why, what is the impetus for me to be doing what Dimitris mentioned, mainly working on advancing non-invasive multimodality integration. Why do we need to do that? We're going to go through this, and it may be a little tedious, but we, for those of you who are not familiar with these techniques, I think it's important to understand a few of the biophysical principles. And then I'm going to look at previous work in presurgical localization, and I'll talk to you about our clinical experience and hopefully future directions. Now, having said that, I do not necessarily need to go through my slides, and so you feel free to interrupt me and ask questions, as we go. Maybe later on it's going to be not as easy to go to the same concept. So I'm very happy to interact rather than go through my slide deck. Right, so this is Hans Berger. Hans Berger was a psychiatrist, not a neurologist, who was ridiculed because he claimed that he could record electrical signals from the brain. And he was ridiculed by people who had a major stature in the field at the time. So this is the first published EEG, appeared in 1929. He used this to show that what he's recording is not an artifact. It's a single channel EEG recording of the posterior background, which is recorded in the occipital areas, in his son. That's in 1929. And this is his laboratory in Jena in the 30s, right? And, things have changed over time, but the principles are the same. Now, this is the first MEG room. This was in Boston, and this is the first recording by Cohen of the correlate of EEG, which is the magnetic activity of the brain. And what you can see here, that's a single channel also MEG. And what you can see here is a shielded room. that is so shielded that it cannot exist on any building apart from the basement. It's extremely thick and weighs, I don't know, many pounds. So in the 70s, we realized that we can record magnetic activity, but MEG did not become clinically applicable until the time that we had the modern devices which allow recording that is very dense and recording from the whole head. So what is the problem here? Now, for those of you who are not involved in epilepsy, you know that many of our patients can lead a normal life. And that's our goal. Our goal is to make them seizure-free and, for them to have an excellent quality of life. Now, unfortunately, there is this subset of patients who have medically intractable epilepsy, meaning they will not respond to medications. And this may be de novo from the very beginning or may develop across the course of the disease. And this is not unique to epilepsy. Intractability is not unique to epilepsy. The medical intractability is something that may be inherent to the way our biology of the host is, right? And so we see it, for example, in treatment-resistant depression and other conditions related to the brain. So there are definitions that have come out regarding intractable epilepsy. What is important to mention, though, is that depending on who you read, estimates are that at least 1/3 of patients will have intractable epilepsy at some point, maybe even 40%. And you can imagine the consequences of having intractable epilepsy and frequent seizures that do not allow for you to drive and comorbidities that go along with that, and also the costs for the patient, for the caretakers, for the society, and the loss of employment at a young age. Now, there is epilepsy surgery out there, and it may be appropriate for more than 50% of these patients. And in fact, it may provide another chance to a normal life. Now, depending, outcome studies in epilepsy surgery, difficult to interpret because they come from various centers and various misconceptions around how things are done. But to make it more simple, simplistic maybe, you can see that depending on how complex the epilepsy is, you can have an inverse relationship to the degree of cure, and I don't think epilepsy surgery is cure, in fact, but it actually eliminates the major problem. So maybe 2/3 of patients could become seizure-free, and some maybe are taken off medications. In general, I do not take my patients off all medications. And even those who are not seizure-free may show improvement. Now, therefore, we need to accurately localize where the epilepsy is coming from in these patients to make it successful. And the localization, the ability to localize the epilepsy, the concept of the epileptogenic zone is dependent on the tools that we have at any time point, right? So the very first recordings were intraoperative and were with direct electrocorticography, and they were in Canada, with a Canadian neurosurgeon and an American neurophysiologist. And that were done in the 50s. And obviously, in the operating room, you are limited in terms of exposure and in terms of time and in terms of anesthetics. In the 70s and the 80s, the Europeans and the North Americans took kind of a different approach. And there is this dichotomy between what is called the stereo-EEG, stereo-encephalography, which is stereotactic placement of depth electrodes according to an anatomoclinical hypothesis. And this now allows for extraoperative recordings, so the patient can be ambulatory, it can be in the monitoring unit, and you can record the seizures. And so you don't only get ictal information, interictal information, but also you have ictal information. And at the same time, in the US, we went in a different approach, which was the subdural recordings. And you know what subdural electrodes look like, but these do not allow recording from deeper structures. So there are pluses and minuses, and therefore nowadays the trend is that also in North America, stereo-EEG is becoming a major way to evaluate these patients. Now, why do you need all that? Okay, because the scalp EEG has limitations. It's imprecise, it cannot usually detect the initiation of the seizure. Why is that? Well, you're not going to be able to see something that's coming from deep. You're not going to be able to see something that's coming from a mesial structure like this. We never see a discharge that involves the hippocampus only on the scalp. So it has to involve a relatively extensive cortical area for it to be appreciable because of the biophysical principles and the resistor, which is the bone, the major resistor. So you cannot see things that are in the depth of a sulcus, for example, and in the base of the brain. Now, what are pre-surgical evaluation tools? Well, the first epilepsy surgery was done based on seizure semiology in a patient who had foot clonic seizures. And there was no EEG at the time. It was in the 19th century. But as EEG evolved, then we make electroclinical correlations. And MRI obviously revolutionized our ability to move on to surgery, as well as neuropsychology. But we're also using these other tools, PET and SPECT, MEG, and functional MRI. And when we have doubt, we move to intracranial EEG. I showed you the subdural and the stereo-EEG. So there are various indications that we want to move to intracranial EEG. And you can see here, you can imagine why we would need that. There is conflicting information coming out of the non-invasive data. You have patients who have a normal MRI, and things are more difficult, more challenging in these patients. You have focus that may be a subset of an extensive lesion that cannot be resected. You want to know about the eloquent cortex surrounding the area that you want to resect, or you want to find out what the dominant epileptic area is. So we have to move from the non-invasive to the invasive recordings. And it is extremely important that before we do that, we have a solid, well-defined hypothesis, because there is a limit on what can be covered. And I want to demonstrate this to you. So these are the types of electrodes. Obviously, a large craniotomy for subdural electrode array. This is less morbid in a way. This is stereo-EEG with various trajectories that have been defined before surgery. There are advantages and disadvantages to those techniques, and we can discuss this. But importantly, there are limitations. So we cannot record from the entire brain. It has been calculated you will need about 10,000 recording sites with a 3.5 millimeter resolution to be able to get information about activity from the entire brain. Now, I'm pretty sure Dr. Serletis can do that, right? but that's not our goal. And there is a need for additional surgery. There are surgical risks. There is cost. And I have to tell you, even after you get the data, it's very hard to make 2 or 3 neurophysiologists agree on what it shows. Okay, so it's difficult to interpret. And there are complications, various papers that show the complication rate is not high, and certainly the risk does not outweigh the benefit by no means. There are questions also as to whether there are potential long-term risks of implanting these electrodes. And these are more theoretical questions, and damage to the neural tissue, deposition of iron. We looked at the various common pathological findings on the specimen that has received the implanted electrodes and then was resected. And so you can see an acute microinfarct, you can see chronic inflammation, or you can see a microhemorrhage. We don't know the significance of those, but certainly this is something that you can identify on pathology. And as you can see here, which is basically a summary of what we found, we looked at about 100 patients, and each dot is an individual patient. And these are the patients who have one of these complications, micro-complications, and these are patients who do not. And after 2 weeks of implanted electrode, virtually none, virtually all patients have complication. Now, we consider the intracranial EEG as being the gold standard, and this is the elephant in the room. So why not? Because a well-localized intracranial EEG does not necessarily imply good surgical outcome. So we can then sit down and tell Dr. Serletis, I know exactly what the stereo-EEG shows. And then we make a resection, it goes ahead, but the patient doesn't do well. Or vice versa. You may have a non-localized cranial EEG, but Dr. Seletti says, oh, you know, a current and a field. And so whenever you have a current, you will have a correlated magnetic field. You can see this in this diagram. So if this is the direction of the current, then if you use your right-hand rule, obviously you will have a field that is tangential to this current, as seen here. Now, it's important to understand that the direction of the electrical field or the electrical dipole will define how the magnetic field will project on the surface. So, in general, dipoles that have a radial orientation will not project very well on the surface. Dipoles who have a tangential orientation, on the other hand, will project, and therefore, MEG has advantages for things that are sitting within sulci, which is a place that we cannot evaluate so well with scalp EEG or with subdural electrodes. Therefore, as you can see here, the direction of the dipole is, of the electrical dipole is this way, and the magnetic field that you can actually pick up in a tangentially oriented dipole is excellent. Now, there is this idea that when you have radial activities, then the MEG will show nothing, okay? When you have tangential activities, the MEG is well suited. Now, this is more theoretical because we have many, many sensors, and therefore there will be some tilted activity that you can actually identify. Now, the MEG is a complicated system, so it requires a number of things, and it requires a physicist that will be involved, and so the resources that need to be implemented are not insignificant. This is the sensor array, and you can see that we have up to 306 channels that can record now the magnetic activity from the brain. And so you can look at, a top view, and you have 306 little waveforms that you need to analyze. However, there is a big problem, and I'm sure you've heard these terms, the forward problem or the inverse problem. So essentially, if you place within, let's say, a model of the brain or a sphere, a battery, and you know what this battery is doing and the location of it, then you know exactly where it is in that conductor, then you can deduce how the activity will project on the surface, right? So that's the forward problem. But the reverse problem, if you have something on the surface, then you don't know exactly where the battery is. So you have to make assumption. Now, modeling of MEG activity, magnetoencephalography, is easier than modeling EEG. Why? Because magnetic activity doesn't care about the conductor, the resistance, which EEG does. Therefore, for example, in patients who have like a craniotomy, or who have a subdural hematoma, or who have previous resection, who have an extremely big lesion, you don't have to deal with the changes in conductivity. Modeling, therefore, of the conductor is easier, whereas it's much more complex with EEG because you have to model 3 spheres, essentially the skull, and the brain. So the sensitivity of scalp EEG, people suggest maybe more, in order for you to record it, you need more than 10 centimeters square of gyral surface. And it looks something like that. In summary, this is a slide I borrowed from Dr. Ebersol, who has done a lot of work. And so you can see things that are on the surface. Whereas MEG is probably more sensitive, requires less cortex to be involved, and I told you about the tangential orientation, which results in your being able now to provide some sublobar localization and in fact look at gyri, which is extremely important because, as we know, only 1/3 of the brain is sitting on the surface. All right, so it's more likely that the epilepsy is coming from deep. So I told you that the activity is not attenuated or distorted by bone and scalp. I told you that it has higher source resolution. It has no exposure to radiation. It's a magnetic field. In fact, it's very easy for a patient to get an MEG. They just sit there either on a seated position or lying down. But it has limitations. So the most important limitations is that you are using a model. You make mathematical assumptions. And it has the same limitation that EEG has, that you cannot see very deep sources. So things that are very deep in the brain, unless they have a very high intensity, you're not going to see. Recording of ictal phenomena is rare, and the resources to implement it are both expensive and labor intensive. Now, what is the model that we use for the most part in clinical MEG? It's a simple idea that a population of a patch of the cortex that is actually activated by the epileptic activity could be represented as a dipole. Now, the dipole is very schematic, right? But if this is the case, then the dipole will have a position, will have an amplitude, will have an orientation. However, it is very important to understand that this is a theoretical concept, and it's a representation of activity that involves considerable cortical area, because I have seen, sometimes people say, okay, if we have like a few dipoles in that area, it's a visual, determination of the exact area that needs to be resected. And in fact, I was criticizing other people before for petectomy and spectectomy, but this is from our center, and somewhere here is my name, and we called it clusterectomy, and which is not an acceptable idea. And so we have to remember that all models are wrong, but some are useful, and this is more useful than others. And what you do then is you look at what the magnetic fields appear on the array, and then which kind of dipole would explain the best this activity with the least residual. Now, you can then perform what is called magnetic source imaging, which means that you relate now the area that you have identified as, the area that has the highest probability for the dipole being there to the patient's own MRI. And how do you do that? Well, you use the same thing that you use in the OR sometimes. You use fiducials, and so you use landmarks, essentially the two preauricular points and the nasion and the ilion, and then relate those exact landmarks with these areas on the patient's MRI, because the patient head can easily move inside the scanner. And so you use the head-based coordinate. So here is how we do that, and we're taking these fiducials, and in fact, we also apply other EEG electrodes also, so that we can have simultaneous recordings of scalp EEG and MEG. Now, there are also head positioning coils that, in case the patient moves inside the scanner, these coils help you actually correct for movement. And therefore, now the neurous systems allow you to actually also analyze the magnetic recordings from the beginning of a seizure, let's say. Now, remember that the Earth's field is 10 in minus 4 Teslas, and what we're trying to record is maybe 10 in the minus 12. So therefore, we need passive and active shielding, and therefore you need to apply algorithms that will clean the signal and that have been validated. Now, I know this is a little tedious, so I want to actually make an analogy. How do we fill in the gaps? You know about this very unfortunate situation with the Malaysia Airlines flight that was going to go to Beijing, but it was diverted somehow, and we don't know exactly where it ended. But what we knew in the very beginning is we had some information from radar that it could actually be in the Gulf here of Thailand, or could be moving to the South China Sea. And then some people said, no, it took the other way and went to the Strait of Malacca across Malaysia. Now, assuming this plane is the epileptic focus, then if you put electrodes here, if your hypothesis is wrong, obviously you're not going to find it. And if you put electrodes here, obviously you're not going to find it. So we were looking in the wrong place, right? But then, many days later, satellite data showed up. And so, assuming this is your non-invasive information now, this is your MEG or your EEG or whatever information you think it is, you were able to then say, well, no, I think it is within this area. Therefore, it gave you perhaps some lobar idea. So we know it's not on the Atlantic, right? but we know it's in the Pacific, and we think maybe it's in the South Pacific. And so then 2 trajectories were drawn, and what Dr. Seletis would like to know is this probability map eventually, which says here is the highest probability that the plane is ended up, or it could be on the north side, which was eliminated, making an assumption that it went south, and this is a lesser probability. And therefore, this is where you need to actually focus your invasive evaluation. Now remember, despite that, we haven't found this plane, even though this is the most expensive exploration in aviation history. And that is to say that intracranial EEG is also expensive. It's also costly. Now, what about previous work in pre-surgical evaluation? I would think that these are the indications. So as I pointed out, planning investigations, intracranial investigations is important, pre-existing cranial deficits, extensive lesions and multiple lesions, and normal MRI. Functional mapping also, I'm not going to discuss this, maybe situations where you have bilateral synchrony, and maybe situations where the EEG is normal. Now, there are a lot of studies in this area, but the most important, that provides sort of class 1 evidence is a randomized trial, which was done in the University of Alabama, and I think that's the most important trial that has been performed, essentially making a plan without knowing the results of the MEG, and then revising the plan after being unblinded. And the major finding is that a conclusively positive MEG or MSI, magnetic source imaging, has a high predictive value for seizures that will be localized by the EEG. And what is a conclusively localizing MEG? So here are individual dipoles, equivalent current dipoles, that have been applied for individual spike events that were identified during the time that the MEG was recorded. And a source that displays temporal stability, frequent discharges, localized within a dense cluster, fairly uniform orientation, that's a conclusive MEG result. And if we think about what we know from our investigations, for example, in the operating room or, in subdural evaluations, in electrocorticography, we know that continuous repetitive discharges that are commonly displayed by cortical dysplasias will actually satisfy this idea. So if you can identify those, you probably are in the primary irritative zone. We have also, looking at prediction of epilepsy surgery outcome, and from this same cohort, MEG performed better than PET and SPECT in each of the metrics that were gathered. We have also analyzed our non-lesional normal MRI patients in our group, and we actually found that MEG and intracranial EEG agreed the most and predicted the most favorable surgical outcome. So if you look at odds ratios in this table, you can see that when combining intracranial EEG and SYSCOM and SPECT, the chances that you're going to be seizure-free were not that high. However, if there was concordance between intracranial EEG and MEG, these patients did well. Of course, if all the non-invasive is in agreement, that's even better. And another thing that you can do is perhaps, and we'll discuss this, if you have a non-lesional case, and you are able to identify things with using algorithms, no longer visual analysis on MRI. Some people look at the thickness of the gyri, others look, for example, here we looked at gray-white matter blurring in distinction fuzziness. You might identify some areas that are candidate areas, but you will not know, you will have perhaps many false positives. But if you can relate, that's a sublobar area. If you can relate a positive MEG, then probably you're transforming a non-lesional case to a subtle lesional case. And we have showed that in terms of looking here at what the algorithm identified, what the MEG identified. Now remember, these were non-lesional cases. And what eventually the resection was in retrospect. We looked at in retrospect. So we did not have the algorithm at the time. And these people did well. Whereas if there was discordance, these people did not do well in general. Now, let's look a little bit at the fMRI signal and bold imaging. This is an interesting story. So this is an Italian physiologist called Angelo Mosso in the 19th century. And this was a villager, a peasant named Michel Bertino, and had a skull defect from an accident. And what the physiologist was able to identify is when recording pulsations from the skull, whenever he asked the patient to do some simple math, he would see that the pulsations increased. And similarly, this is a neurosurgeon at Brigham. No, actually, this is a physiologist, and Cushing operated on this patient who had an AVM. And whenever he was involved in cognitive activities, such as reading, again, you would see an increase in pulsations. And this is a phenomenal experiment, groundbreaking observation that was done in rats. And these are rats that were breathing room air, and you can see the vessels here. And these are rats that were hyper-oxygenated, and the vessels disappeared. So in an exogenously oxygenated state, you could see some changes that suggested, that the flow had changed in that area, or perhaps the oxygenation had changed in that area. And therefore, the question was, does this happen also in the situation that the physiologist had already identified, which is by endogenous oxygenation? Obviously, this was done at a very high magnetic field MRI in rat brain. And so we then identified this idea of neurovascular coupling, which means that neuronal activity somehow informs the proximal vessels to increase perfusion. So what ends up happening is the oxyhemoglobin and the oxyhemoglobin have different susceptibilities when you look at them with the MRI. So this is in the deoxygenated state, which has a higher fraction of the oxyhemoglobin compared to oxyhemoglobin. However, when you have a response to neuronal activity, localized neuronal activity, then flow increases. And when flow increases, it's interesting that the oxyhemoglobin increases. And therefore, now you have less deoxyhemoglobin and more oxyhemoglobin, producing less dephasing and no black signal. I can show you a movie of that here, or I cannot show it to you, but it's not that important. So now you look at the hemodynamic response function, and what is important to understand is that the neuronal activity happens at time zero, whereas what you pick up on the bold changes, the blood oxygenated, the oxyhemoglobin-related changes, actually picks up a few seconds later. And depending on how you read, it's probably within 2 seconds and also continues to pick up later. So you will understand now that the bold-related changes related to neuronal activity, in fact, may reflect propagated information, right? Because they do not happen at the exact same time as the neuronal activity. And we know that there are situations in clinical EEG where spikes propagate within milliseconds. And therefore, if what you're identifying is 2 seconds later, it may be that you're identifying the area where the spike has propagated to, or a network that has been activated as a remote network as a result of having a localized spike. These are experiments with penicillin-induced seizures. These are in sheep, and penicillin is a chemoconvulsant, and you can give it systematically or you can give it localized. For example, here is the injection site, and here is the amygdala on the same side, which shows that the amygdala actually was having a seizure at the time that the penicillin was given. Now, there are many other things that you can do with functional MRI and with MEG. For example, you can do mapping of information, but I'm not going to talk about that because I said my interest is localization. And in fact, we have to remember, this is an aphorism by Hippocrates, that art is long and life is short, and therefore we have to pick our battles. Now, how do we obtain simultaneous recordings of EEG and fMRI? This is a harsh environment. The magnetic environment is a harsh environment. So this is a commercial EEG-fMRI instrumentation that became available perhaps in the last 10 years, that is able actually to eliminate the noise of the recordings. We are using a checklist when we do that, and remember, we do this as part of research. This is not used for clinical work at this point. Now, having said that, it is used in institutions outside the US. Now, we have a list of what we need to do so that things are done in a safe way. We apply an EEG cap. It has 68 channels, and so the electrodes are not really affixed on the brain. The cap may move, and so you may not have excellent position of the electrodes. And then you have a preamplifier, which is in the magnetic room, but it's a safe preamplifier. So this is a costly system, and you have to deal with impedance, and so you have to correct impedance so that you can obtain the best EEG waveforms. So you need an MRI-compatible preamplifier, an isolation unit, and this is what gets inside the magnetic field, and then a wire transfers the information outside where we have the recording equipment. So this is an MRI EEG-compatible system, and this is the local amplifier, and this is the optical fiber that takes us to the interface looking at the signals. Now, there are challenges. The precise head placement of the cap, I already mentioned, having low levels of impedance, and actually it's not very comfortable for the subject to have these many electrodes and then be lying back and being immobilized within the scanner and then listening to what the scanner is producing. So here is a subject, and what we absolutely need to do is make sure that we don't have any loops in the way the cables are connected, because that can generate heating and so on. So the premise is similar to MEG. You record for about 60 minutes of interictal activity, and then you get something like that. So whenever the scanner goes, there's a gradient echo, the scanner starts recording, you basically don't see any EEG signals. And therefore, here with a sensitivity of 1,000 microvolts, you see the extensive artifact, and I don't think you can identify any abnormalities on this record, but when you use this algorithm, you will be able to see that, in fact, there is a spike here. It's a temporal or frontotemporal spike on the right side. So these are the post-process data. Now, we discussed the intracellular currents that generate MEG, and we discussed the oxygenated hemoglobin changes that indirectly reflect neuronal activity. We discussed that these functional images are directly related to the structural images. What you see, the bolt, is actually there, whereas in the MEG we discussed that you correlate a centroid, a dipole, a model to the patient's anatomy. So the imaging depends on source and head models. You don't have to do that in functional MRI. And spatial resolution is higher with functional MRI. But time resolution obviously is better than 1 millisecond, whereas in functional MRI, time resolution is low. And for deep sources, MEG is not useful. However, fMRI can show you also subcortical activities and basal ganglia and so on. Now, there is, however, an advantage in that any institution has an MRI scanner. And therefore, you can more easily approach this question by using the system that I just described to you. And that system is not that costly. It's about, I don't know, depending on the vendor, around $100,000, whereas the MEG is in the million and more. And therefore, if you have a 3 Tesla scanner and if you have people who are motivated and interested, you could actually approach this EEG-fMRI business. Now, I talked to you about petectomy, clusterectomy, and all of that. Obviously, there should be some EEG-fMRI ectomy also, right? So previous work in presurgical localization at other centers, and there are many papers, if you look, in PubMed, papers have been published since 96 and have increased a significant amount in the last few years. So this is the process. You acquire the data, and in the scanner, you post-process the data, you look at statistics, then you identify single spike events, and you relate that timing to the bold responses that you can see. However, there are limitations which relate to safety, which relate to artifacts, continuous scanning, gradient artifact, and something that people do not mention, but us neurophysiologists understand, that is, you really cannot see those spikes very well. So you may be misled by something that is not a spike, and you may miss spikes because signal-to-noise ratio is low, and also they don't look anything like what they look, in real life, what they look like outside the MRI. Now, previously people said that bold is detected in 100% of studies, but actually now we know that you can have EEG spikes and no detection of bold changes, and vice versa. So that's a problem. Now, there are some new possibilities, and what can you do if you do not have any spikes? And can you do functional MRI only and look at resting state activity and do not need the EEG and conclude based on resting state bold changes that maybe that's an area that is epileptiform and so on. Now, there are many studies, and I'm not going to spend time showing them to you. Certainly, more studies have been done in temporal lobe epilepsy. And this is temporal lobe epilepsy with hippocampal sclerosis, which is a scenario where we really do not need, and in general, we do not need these non-invasive investigations. We would never use an MEG in somebody who has hippocampal sclerosis and concordant information. It's not necessary. It's a waste of money. And we will not do that with EEG-fMRI. Therefore, because most studies of EEG-fMRI have been done in temporal lobe epilepsy, they are less relevant to our clinical practice. But this is a situation where you can see that there is concordance with the left temporal focus here, right temporal focus that is concordant to the hippocampus that is sclerotic. There are a few studies in non-lesional epilepsies. However, this is actually work that is multi-center and multi-national work to identify these patients. I think centers from Brazil, maybe from Canada, and certainly from the United Kingdom. So the results have yet to be published as far as I know. There are also situations, both in MEG, in fact, and in EEG-fMRI, where you can record ictal information. So how do you do that? Well, people may have a seizure in the scanner by serendipity, or there are also the situations where people have what is called reflex seizures. So in response to a particular stimulus, you might be able to induce a seizure reproducibly inside the scanner. This is a case, I'm just showing it to you in ictal EEG-fMRI. In fact, in our MEG laboratory, about 10% of our patients have seizures that in most cases we can localize them. And here is the intra-MRI EEG. And this is the beginning of the seizure. This is the evolution of the seizure. So by cleaning up the signal, you can see the seizure. And you can actually, in these cases, obviously identify bold changes. And these are positive bold changes and negative bold changes. So these have also been reported in the literature. However, even though in the beginning the idea came out that you can actually identify what you're looking for, now people who have been working on EEG-fMRI for several years actually have started to conclude that the changes do not reliably and always reflect the irritative zone. And Laufs is one of the major leaders in this area. I would like to show you a case or two from our center. My interest here is to have patients evaluated both with clinical MEG and with EEG-fMRI and relate the findings to ground truth, which may be the result of an intracranial evaluation that actually looks at the areas that have been identified by the studies and ultimately surgical outcome in people who have resection. So this is a straightforward case of a 33-year-old man who has seizures starting at the age of 15, and he has a typical aura complex partial seizure evolution, suggestive temporal lobe epilepsy. Similarly, his evaluation showed the spikes and seizures coming from the right temporal lobe, and he had right mesial temporal sclerosis. And I just told you that in this case, we don't need the MEG. However, it was done as part of research. We had a positive PET. So this is a patient who would be a prime candidate for right anterior temporal lobectomy based on all studies that include class 1 evidence and has a high likelihood of becoming seizure-free. So this is the result of the MEG. You can see now that, in fact, the MEG may show some sources that are mesially, and as is commonly the case, show sources also in the anterior temporal lobe involving the neocortex. And this is the result of the EEG-fMRI. And here, this is in neurological convention. I'm sorry, these are small, but this is how we calculate the results by convolving the hemodynamic response to the spikes that we identify. And so it is in an appropriate place. And here now I'm trying to illustrate where the MEG is positive and where the EEG-fMRI was positive. And you can see that they are not identical, but, and I'm sorry, this doesn't show, but you can see from the images, these are in the same space, that MEG is more anterior, the EEG-fMRI is more basal. And so there is sublobar concordance. What is the ground truth? Well, this patient has been seizure-free now for almost a year. Now, there is another patient, though, where we have many difficulties. So this is a patient who's 28, started having seizures at 13, failed epilepsy surgery when she was 15 years old. So failing epilepsy surgery doesn't mean that you're not a surgical candidate. It's a very important point. Now, she had, and we saw a case yesterday actually in the conference, she had extreme head-eye turning to the right with full retention of awareness and maybe eye fluttering. And this, he had them, daily and multiple seizures. And we had an EEG that suggested that it's coming from the left, maybe ventral frontal lobe. And so the interictal and the ictal EEG was concordant. We had a nice ictal spect that you can see here. So it lights up in the perhaps transition from dorsal to ventral frontal lobe. And here is the area of the previous resection. So the previous resection was done in the operculum. And so it would not involve the premotor area and frontal eye fields that probably are activated with the said seizure. And in fact, when this resection was done, the seizure type did not change, suggesting that, the area where the seizures were coming from was not resected. Now, here's the problem. She had a functional MRI for language, and it did not make sense. So the conclusion of the neuroradiologist is the findings likely reflect altered hemodynamic response in the setting of a patient with seizures and previous surgery. Therefore, conceptually now, if this is the case, which was an assumption, we don't know for sure, if this is the case and you have neurovascular uncoupling rather than coupling, then you cannot use EEG-fMRI. But you wouldn't know that if you're using EEG-fMRI, right? So this is the result of her MEG. It is a highly localizing MEG, as you can see here. It's close to the inferior frontal sulcus, in the middle frontal gyrus, anterior to the area of the resection. So that's where the MEG lights up. I told you that you can see gyral sources, and I told you that the resection was a little bit behind. Now, what about the EEG-fMRI? Again, by neurological convention, this is the left side, but it's the temporal lobe. And this is the left side, but it's the occipital lobe. And it did not implicate the area of the previous resection. So here you have disagreement at the lobar level. Now, this is a patient that was evaluated with intracranial electrodes, and I can show you the data, but what we identified essentially is that the seizure information, the seizure activities were actually coming from the conclusively positive area on the MEG in that particular gyrus and adjacent sulci. So this is the evaluation that was done in this case. This was not a stereo-EEG case. This was done with subdural electrodes, and that included some 300 depth electrode placement in the areas of interest. And the only reason these electrodes were placed there is because you were guided by, you were placed in the sulci because you were guided by the information that you had, obviously, from the MEG. And so these are the electrodes that were picking up the activity first and earliest. The reason we did subdural evaluation here is because we wanted to know proximity to motor areas that should not be resected. And in general, subdural electrodes are better for functional mapping. So functional mapping was done, resection was done in that area that included those electrodes, staying away from motor cortex. You can see here the placement and so on, and the patient became seizure-free. Therefore, we had a problem here in terms of discordant information. Now, I just showed you two patients. You know, I wanted to understand the concepts, integrate the concepts I presented earlier to you. I have a series now of maybe 9 patients who have been evaluated this way, and this has not previously been discussed in the literature, so I would like to contribute this information when we complete this study, hopefully in the next year. So what is the future? There is resting state fMRI. So there are fluctuations of ball changes that occur in the brain at resting state. So can you, instead of looking at spikes and recording EEG, may deduce which areas are producing some phenomenon that can be identified by resting state, and this be the epileptogenic areas. So what is the idea behind resting state fMRI? You can see here that there are normal resting state fluctuations of brain activity that are reflected on the ball, and then you try to correlate various areas, and you can see that these two areas have similar activity versus, you know, in the anterior frontal lobe, these are dissimilar. And therefore, you can say that there are clusters that correlate with each other. And so this has been done in terms of understanding functional networks, and it's a very interesting area of research. Multiple networks have been identified, including what is called the default mode network. And then people said, well, maybe we can do this with or without spikes. So that's an important idea. Now you do not need spikes in order to get to this information. So you do not necessarily need to record the events, but look at ball changes. But again, understanding that the ball changes are indirectly related to where the spikes are coming from, or to where the activity is. We are a little bit beyond time, so I don't want to give you more details unless you would like for us to look at it later. However, we also have the same problem in MEG. We have MEG spike negative cases. So looking at this patient, for example, it's an illustrative case. And the reason I present these cases is, again, to go over the same concepts that we discussed earlier from the practical standpoint now. So it's a patient who has a negative, no interictal discharges video EEG, and a single seizure was recorded that was right temporoparietal. Now, we did a stereo-EEG evaluation, and we found, in a particular area where the depth electrode was, very tiny spikes that will never be seen on the surface by virtue of them having a very low intensity signal. So here is a depth electrode, and these are the more distal contacts and the more proximal contacts, and you have involvement of only 2 contacts. It's impossible for that area that is being activated to be seen on the scalp, either by EEG or by MEG, explaining the fact that the EEG was negative. And of course, we actually did something quite interesting, is we recorded simultaneously what the stereo-EEG was showing, so the intracranial electrode, with what the MEG was showing. These are simultaneous MEG, intracranial EEG studies, and obviously the MEG said nothing. It was normal, okay. However, you're going to ask me, so how did the surgeon know where to put this electrode, okay? Because, you know, they hallucinated somehow and said, well, in the posterior part of the superior temporal sac, there may be some indistinction. Now, this is maybe true, maybe not, but it's worthwhile exploring, and therefore it was explored, and it turned out to be true. You're not going to be able to see it, you know, on these. There was some increased signal intensity also. Okay, so you can look at this data with your MEG and make some correlations, how much tissue is activated, what are the distances, what is the intensity of the signal. And this is all very interesting for neurophysiological purposes, and we can write nice papers with that, but it doesn't help the patient, right? So therefore, we said, okay, we're going to try to do something new, which is localize the focus based on the resting state signals. And we're not going to care about interictal spikes. And that goes away from the premise I discussed with you earlier, that interictal spikes can help localize the epilepsy. And now, assuming that resting state data, irrespective of the presence of spikes or not, can localize the epilepsy. And in fact, even though this is quite premature, now we were able to demonstrate, this is the first time this was demonstrated, that based on resting state interictal magnetoencephalography data, you can identify the focus. This is ready, it's been accepted, it's not yet on PubMed. This is the proof, the draft. So I think I talked to you a lot about some of the future directions. Also, we have other things that we're doing. We're stimulating electrodes inside the fMRI scanner. This is work that is done by colleagues of mine. So therefore, I think I need to conclude here. We went over a number of things. Remember the history, the problem that I discussed with you, the basis of the signals, previous work in pre-surgical epilepsy, and including experience from our laboratory, and some things that may be coming in the future. So there are EEG spikes that do not have fMRI correlate. There is fMRI activation without an EEG correlate. And so there are ways that we can explain these intrinsic discrepancies, but that means that practically speaking, we have problems with EEG-fMRI, and there are limitations. Its utility in temporal lobe epilepsy is relevant in our practice. So it may need larger cortical areas for it to show up, and obviously you may have propagated activity. So I view EEG-fMRI more like a interictal SPECT study where you can see propagation of the activities. And I can illustrate to you how fast spikes can propagate. So activation of the EEG-fMRI is part of a network, and EEG-fMRI data show a long transition from interictal to ictal state. So there are complex changes in the elements of the network is involved in epilepsy in EEG-fMRI because what you are looking at is indirectly related to the phenomenon you want to localize. So we have powerful tools to explore epilepsy networks. Combined use of MEG, EEG, and fMRI may provide unique insights, but integration makes sense only if the same kind of activity is being studied with different techniques. And even in this case, it's important to take into account inherent limitations, and that's one of the things I tried to illustrate today. I don't think there is a better technique or a worse technique. Obviously, depending on where you practice, people think that, they have expertise in PET, they have expertise in SPECT. I may think I have some expertise in MEG. And I told you that there are centers in the United Kingdom who actually make clinical decisions with EEG-fMRI. So I just wanted to mention that it takes a village to do this kind of studies. There are many, many people who are involved, and I'm very grateful to these people, and it's also very exciting to be working with them. I wanted to mention the director of the MEG lab, Dr. Burgess, and the director of our center, Dr. Najim, and then some very bright people who we work with. And Dr. Steve Jones is our neuroradiologist, very closely working with us. Dr. Krishnan is doing the electrophysiology, and Dr. Wong is doing mainly the post-processing of MRIs. And with that, I wanted to thank you for your attention.
That was great. Thank you, Andreas. That was a masterful talk, and it highlights some of the exciting innovations in epilepsy. It shows that epilepsy and epilepsy surgery is making a huge resurgence, in large part because of these techniques, these technologies. So things are getting quite exciting in this particular field. Andreas, thank you very much for coming to give the talk and for spending the day with us today. You'll meet various parts of our epilepsy team, and we just hope to learn from some of your experiences clinically and research-wise and professionally as well. So thank you once again. A special card for thank you.
Thank you.
And we greatly appreciate it.
Thank you, Dimitris.
Excellent.
Right, right. So I have not seen somebody who can reliably identify high-frequency oscillations in the MRI scanner. So that's a problem. And having said that, we have the same problem in MEG. We have cases we identify high-frequency oscillations, but is much less common as compared to the patient's intracranial EEG. And the reasons for that is, again, because of low signal-to-noise ratio and the fact that you have to do shielding. And so even though our MEG environment is very much clinically oriented, the MEG device is sitting on the second floor of the building, so it is, less thick and, it weighs less. It has a single shield as opposed to the three-layer shield that is best for passive and would do active noise cancellation. And we are able to remove artifacts from VNS and other neurostimulators and record in these patients. We cannot go to the cleanest signal possible. But for purposes of spike localization, I think that's good enough. Thank you. Thank you. Huh? Thank you. Thank you. I'm delighted to be here. I appreciate it very much.
Thank you.
Good.
Thank you.
Sure. Yeah, isn't it? Yeah? Interesting stuff, eh? Yes. Yes. Isn't it? Yes. So it has to be, the signal has to be there. Yeah, and there has been work in EEG, but EEG is very undersampling, and to do that.